Essentially, there were previous data from the Eurocare 5 analysis showing that survival outcomes for older cancer patients in the UK are poorer compared to other high-income countries. There are also data from Public Health England showing that there is variation in the use of systemic anti-cancer treatments in older patients across the country. So we really wanted to have a look at the degree of variation in the use of systemic anti-cancer treatments in older adults. And essentially, we thought that using the systemic anti-cancer treatment SACT dataset of Public Health England was really a good way to assess that. So we set up a group composed by oncologists, geriatricians, epidemiologists, statisticians, and essentially we looked, we designed a population level cancer registry based study, and we looked specifically at particular stages and of breast cancer patients, non-small cell lung cancer patients, and colon cancer patients, diagnosed between 2013 and 2015. To look essentially at how they've been treated with STEMI treatment across different trusts. We considered stage 2 and 3 breast cancer because obviously systemic anti-cancer treatment is a key component of the management of these diseases. Stage 3 colon cancer because again chemotherapy is a very important component of the treatment. And stage 3B and 4 non-small cell lung cancer because again chemotherapy targeted treatment are the main component of the management of these patients. We linked this data to hospital episode statistics to confirm whether the patients were or not treated with surgical treatment whenever was required. And we also linked data to each single trust, allocating patients to place of diagnosis essentially for lung cancer patients and place of surgery for breast and colon cancer patients. And first of all, we looked at the proportion of patients who had systemic anti-cancer treatments for each one of these cohorts for patients below or above the age of 70 years. And we found that quite a considerable gap between treated patients in the younger cohort as opposed to the older cohort. For the breast cancer patient cohort, for example, this remained significant and quite remarkable also when we consider we just consider the ER-negative population of patients. So those breast cancer patients who require chemo or are not suitable for any other more gentle potentially form of treatment like endocrine treatments. And it was the same in a non-small cell lung cancer patient cohort and in the colon cancer patient cohort. But we also looked at the variation of the use of systemic anti-cancer treatments across different trusts in England, adjusting for other factors that may be involved in decision making, like again the stage, the grade of the disease, the receptor state of a breast cancer patient, the performance status, which means the fitness of patients, their comorbidities. But actually we found that even adjusting for these factors, there was still a significant decline in the likelihood of older patients to receive systemic anti-cancer treatments. And finally, we also looked at the survival rates for these patients. We calculated net survival rates at 2 years rather than relying on accrued survival rates, because obviously in an older population of patients, net survival would also account for background mortality. Competing risk are quite obviously an important problem in the older population of patients. And we found that actually the net survival rates at 2 years for patients receiving systemic anti-cancer treatments do not differ between the younger and the older patients. So obviously, these are observational data, so we need to take these findings cautiously, but it was still interesting to see that, again, there is marked variation in the use of systemic anti-cancer treatment across different hospitals here in England.